This conference will now be recorded.
Today I will be doing this January 2020 of article, that is Lynch syndrome for the gynecologist. Okay, are you getting any background noises?
No, ma'am.
Okay, so this Lynch syndrome, it is autosomal dominant inherited condition, and it has a predisposition for colorectal, endometrial, and ovarian cancers. There are other cancers also associated with Lynch syndrome. We will come to that. But most commonly, these are the cancers which are most commonly associated with the Lynch syndrome. Okay. And this has the most common high penetrance inherited predisposition to cancer. So it has got a high penetrance. So this is the most common inherited cancer syndrome which leads to predisposition to cancer. And what they have found out is why the gynecologist's role is very important in this Lynch syndrome, because what they have found out is gynecological cancer. That means either endometrial or ovarian cancer. These are the first cancer. Okay, these are the first cancer which comes to the diagnosis. Okay, so that's why the gynecologist has a very important role, because it provides an opportunity to diagnose Lynch syndrome before they and their family are affected by further oncological sequelae. Also, it allows women to be enrolled in cancer surveillance programs and enables cascade testing for their at-risk family members. And it enables the uptake of cancer risk reducing strategies. So all these three we are going to discuss in this. So how these mutations are affecting the family members and the persons, what are the cancer surveillance program, and what are the risk reducing strategies in this article. So the cancers associated with Lynch syndrome, these are given in this figure. Okay, these are highlighted. So you can see the colon, that is colorectal cancer, are the most common cancers. See, you can see they are 58%. Okay, followed by endometrium 57%, and then ovary. Okay, so these are the most common cancers which are associated with this Lynch syndrome. So first number is always rectosigmoid, second is endometrium, and third is ovary. But remember that because these colorectal cancers, they are presented late, this endometrial or ovarian cancers, these are usually presented first in this Lynch syndrome patients. Now this Lynch syndrome, it arises from these inherited mutations. And what are these mutations? So these mutations in the DNA mismatch repair system, that is MMR. Okay. So these are the DNA mismatch repair system genes which got mutated, and then what happens is uncontrolled cell proliferation occurs. We will discuss in this next slide. So without functioning this repair system, uncorrected mutation rate accompanying DNA synthesis, it is increased by 1000-fold. Okay, so these mutations go uncorrected, and because of that, there will be proliferative growth of this cells. Okay, and always the individual with Lynch syndrome, he or she inherits one pathogenic allele of that MMR gene. So what are these MMR genes? You can see there are different types of genes. One is this MSH2, MSH6, PMS2, and MLH1. These are four most commonly found mutations in the genes. Okay, so these mutations in these four genes, these are most commonly encountered in the Lynch syndrome. So what are functions of these genes? So you can see this is a break in the gene strand. Okay, so this is the usually during cellular replication, these are the defect which is recognized by these genes, and it gets corrected. Okay, so with the help of DNA polymerase enzyme, this defect they are going to repair. Okay, so these are the repair genes which are going to correct the defects, and this defect in these genes or mutations in these genes, that will lead to this uncorrected defects. Okay, so the epidemiology of Lynch syndrome. Now there are two different types of incidences they have given. Okay, but when there is an infographic of this Lynch syndrome is published in that TOG, no? So now you know they give infographics for different TOG articles. So what prevalence rate they have given is 1 in 278. So if they may ask, you have to answer 1 in 278. Okay. American Association of Gastrologists, they have found that prevalence is 1 in 440. Yes, any doubt? Someone's mic is on. 1 minute. Someone's mic is on. Please mute yourself. Who is that? Yeah, who is this? So the prevalence given in the top infographics is 1 in 278, while American Gastroenterologists Association, they have found out that prevalence is 1 in 440. 3% of endometrial cancers. Overall, 3% of all endometrial cancers, they are caused by Lynch syndrome. Similar thing they have found out with colorectal cancers. That means 3% of all colorectal cancers, they are because of this Lynch syndrome. And this Lynch syndrome, it is not a uniform one because here the degree of penetrance, disease spectrum, and age of cancer onset, it varies according to the mutated gene. So we have seen there are at least 4 genes which are responsible for these mutations in this MMR system. So according to the gene, the penetrance, so which cancer will occur, what will be the presentation, and what will be the age of presentation, all differs according to the mutated gene. So these are the two tables again they have given in the top. So this is the cumulative risk of endometrial cancer. They have given at 40 years and 70 years. Okay. And what they have found out is this MLH1 and MSH2. These two genes are responsible for maximum number of the cancers. Okay. So at 40 years, incidence is 3.1%. At 70 years, the incidence is 42%. Similarly, for MSH2, it is 1.5% at 40 years, 56% at 70 years. And this MHS6 and TMS2, these are responsible for endometrial cancer at around 70 years of age. Similar for ovarian cancer, these two are more important. MSH2. So this MSH2 and MSH6, these two mutations are more responsible for this ovarian cancer. Okay. So I don't think they will ask you the individual mutations, but just remember these 4 mutations are most important for this Lynch syndrome. Now coming to the colorectal cancer epidemiology. So what they have found out is colorectal cancer is the most common and lethal cancer which is seen in Lynch syndrome carriers. The risk of developing colorectal cancer, it depends again upon the gene and sex of the individual. So for MLH1 mutation, the risk is 47%. Okay. Lifetime risk is 47% for MLH1. For PMS2, it is 14% only. Now, what they have found out again is this colorectal cancer associated with Lynch syndrome, it has earlier age of onset. So, median age at diagnosis is 52 years with Lynch syndrome, while 69 years when you find it in sporadic cases. Okay. So, it is an earlier age of diagnosis. Women have low penetrance. So, their risk of colorectal cancer is less, but still it is considerably higher than general population. The surveillance usually done for this colorectal cancer is biennial colonoscopic colorectal surveillance. That means 6 monthly colonoscopic surveillance is recommended for this colorectal cancer for Lynch syndrome. But it requires high quality colonoscopies because this colonoscopic detection is difficult. Colonoscopic detection of this Lynch associated colorectal cancer is difficult because it arises from flat adenomas which are harder to detect. But if you do this high quality colonoscopy, then it is associated with significant reduction in deaths from colorectal cancer. Now these cancers.
Dr. Jadala, sorry to
Yes.
interrupt.
Yeah.
Is biennial colonoscopy, it's every 6 months or every 2 years? Biennial?
Biennial, it should be, oh, sorry, it should be, sorry, biennial, it will be 6 months. Biennial is every 2 years, sorry.
Okay,
Yeah,
thank you.
Thank you. Yeah. So, now another peculiar feature of this colorectal cancers associated with Lynch syndrome, they have propensity for right side of the colon, okay, rather than the rectum or sigmoid colon. So what we have found out, 47% are associated in the colon and only 13% in the rectosigmoid, correct? So it has a propensity for right side of the colon. And what they have found out is synchronous and metachronous cancer. So that means they found out at the same time at different places. So more extensive surgery with iliosigmoidal or iliorectal anastomosis is often required. So this is the differences between the colorectal cancer associated with Lynch syndrome and that with sporadic cases of colorectal cancers. So whenever you are going, gynecologist is seeing the patient of Lynch syndrome, always gynecologists should aim to coordinate this surveillance and surgery with their colorectal colleagues. Okay. So for example, risk reducing surgery, hysterectomies, they should be always combined with colorectal surveillance or surgeries, and always it should be multidisciplinary opinion is very important because colorectal, just 1 minute please. Okay, sorry. Actually, I got call. So always it is important to include colorectal colleagues for any relevant discussions. Okay, Lynch syndrome, because it increases the cancer at multiple sites, and care of this Lynch syndrome people, it should be always a multidisciplinary. So what are the risk reducing strategies to decrease this cancers, different cancers? So women with Lynch syndrome, they should be seen at 25 years by an expert gynecologist. So first visit should be at 25 years by expert gynecologist, so that they should tell to them regarding the red flag signs of the cancers, discuss the family planning, and explore the risk reducing strategies. So once the childbearing is completed, once the patient has completed childbearing, usually the risk reducing surgery offered, that is TAH BSO or total laparoscopic hysterectomy with BSO. It should be offered after the childbearing is completed. Now this timing of surgery, it depends upon the specific gene. So for MLH1 and MSH2, it is at 35 years, MSH6 at 40 years, and PMS2 at 50 years, because you know PMS2, the chances at 40 years are very less. So this MLH1 and MSH2, they require KHBSO at 35. MSH6, they require at 40 years, and PMS2, the surgery is required at 50 years. What they have found out is survival benefit by this surgery, it is minimal, because the gynecological cancers which are associated with Lynch syndrome, they have good prognosis. But whenever you are offering the risk reducing surgery, it should be always coordinated with other risk reducing interventions like colonoscopy or colorectal surgery. Usually, overall, what they have found out, it is a cost effective one is hysterectomy plus BSO at 40 years of age. They have found out in different studies that it is a cost effective strategy. So it is recommended for Lynch syndrome, that is hysterectomy and BSO. Only thing, age differs according to the gene manifestation. Other risk reducing strategies are taking aspirin. Okay, the mechanism why aspirin is associated with risk reduction is not known, but aspirin reduces endometrial cancer risk in obese women also, and so, but the more reduction appeared in obese women than with non-obese women. But still, what they have found out is aspirin can reduces incidence of all cancers. So aspirin is always recommended. Then other lifestyle modification like a healthy diet, healthy weight, regular exercise, avoid smoking, and abstain or reduce alcohol intake to moderate level. So all this lifestyle modification plus aspirin, it is recommended for this risk reduction strategies. Another thing what they have found out is routinely OC pills, they are thought to be protective for this BRCA1 and BRCA2. And Mirena always offers endometrial protection. So the general consensus is that OCPs and Mirena will prevent the ovarian and endometrial cancer also associated with Lynch syndrome, but there are no definitive studies available. But it is a consensus that it may prevent. So all these are risk reducing strategies for this gynecological cancer prevention. Okay. So this is the table where they have given. So if the patient doesn't undergo the risk reducing surgery, then how this surveillance should be done. So they have done a studies using these different methods for this endometrial and ovarian cancer. That is ultrasound, endometrial biopsy, and histoscopy plus biopsy, or for ovarian cancer, ultrasound, CA125, or combined screening like we do for ovarian cancers. But finally, what they have found out, it is a small everywhere. Okay, there is not much evidence available that these will be proved effective. Okay, so the final opinion regarding surveillance, gynecological surveillance, is benefit of endometrial cancer specific survival is uncertain, and literature does not support gynecological surveillance for improving outcome from ovarian cancers. Okay, so for both endometrial and ovarian cancer, not much evidence is available, that is either ultrasound or biopsy, hysteroscopy, or CA125, whether it is going to improve the survival. Now coming to the fertility with Lynch syndrome. So Lynch syndrome doesn't have any effect on fertility. Okay, just 1 minute, please. So Lynch syndrome does not have any effect on fertility, but because it is an autosomal dominant condition, the carriers of Lynch syndrome, they have 50% chances of passing it to the offsprings. Okay, so the passage of MMR gene chances are 50%. Okay, and because of this, according to HIFA, that is Human Fertilization and Embryology Association, what they have found, what they have recommended is PGT or pre-implantation genetic diagnosis is recommended for this Lynch syndrome carriers. Okay, for so that they can avoid this selection of embryos which are MMR affected. Okay, but then IVF is always a demanding process, and many couples who are affected by Lynch syndrome, they prefer to conceive naturally, whatever is the risk. So the uptake of PGT by women or their partners who are affected by Lynch syndrome, it is variable, but still it is recommended. Okay, so whenever the patient who is willing to conceive naturally, she should be always advised that risk of endometrial cancer rises sharply after 40 years. So she should better complete the family before that, and she should not attempt the family after this 40 years, because if they delay the fertility too late, then it will hamper their future fertility plans. It may hamper because of this endometrial cancer. Now, screening for gynecological cancers for this Lynch syndrome. So, as I already told you, prevalence of Lynch syndrome in endometrial cancer is 3%, and for ovarian cancer is 1 to 2%. So, overall, 1 to 2% of all ovarian cancers, they are associated with Lynch syndrome. So, according to NICE, now this is the one thing that you should remember. According to NICE, what they tell is all women with endometrial cancer, any patient diagnosed with endometrial cancer, she should be screened for Lynch syndrome where the resources permit. Now remember this, where the resources permit, this is the NICE guideline. Okay. Now where the resources are limited, testing can be restricted to those where the development of endometrial cancer is before 70 years, or where there are other clinical features, they are suggestive of Lynch syndrome. That is strong family history of Lynch syndrome associated cancers. So whenever the resources permitted, all endometrial cancer patients should be tested for or screened for Lynch syndrome. And if the resources are scarce, then the endometrial cancer less than 70 years or any suspicious features, they should be screened for Lynch syndrome. Now, how to screen for this Lynch syndrome? So it can be clinical and tumor-based detection. So clinically, first, where it is important that you should take a detailed family history to know the pedigree. Okay. So if other family members are associated with this Lynch syndrome associated cancer, there are different tools they have developed for this age and family history based predictions. But finally, what they have found out is because there are different genes associated, it is difficult to use these tools. Okay. But always, if your patient has a strong family history of cancer, it is best to seek advice from genetic counselor. Okay. So you should always refer this patient to the local genetic services. Now, the Lynch syndrome, whenever there is Lynch syndrome, the gynecological cancers associated with it are endometrial cancers, and endometrioid ovarian tumors. These are the most commonly associated with Lynch syndrome. So, after this clinically based screening or clinically based stratification of this Lynch syndrome, you can go for tumor-based testing. So tumor-based testing, it will not identify the people. So it is not for diagnosis, but it is for the stratification of their risk for the condition. So it is used to identify the individual who should undergo definitive screening. So tumor-based testing is not a definitive testing, but it is only for risk stratification. So definitive testing is germline testing, but it is very expensive. So this tumor-based testing should be used for stratification so that the only selected individuals, they will go for this definitive germline testing. So that testing strategies, they will remain cost effective. So what are these tumor-based different type of testing is MMR protein immunohistochemistry. It has a sensitivity of 80 to 100%, specificity of 60 to 80%. Then MLH1 methylation testing. It correctly identifies the tumors caused by somatic methylation events. So it will reduce the proportion of patient who requires this definitive germline testing. Then another testing available is microsatellite instability testing. This microsatellite instability, it is a marker of hypermutation which is seen in Lynch syndrome associated tumors. So the tumors are categorized as MSS stable, MSI low, or MSI high. So microsatellite instability, if it is less than 30%, then or MSI high if the instability is more than 30%. So if it is MSI high, that is 30% of the markers are unstable. So this is the category to which most Lynch syndrome tumors belong. So tumors, they are classified for this microsatellite instability. But MSI testing, it is specific for colorectal cancer, but it is less accurate in endometrial cancer. Finally, the definitive testing lies with this genomic testing. So genomic testing for the tumor is referred as somatic testing, or genomic testing of the patient is known as germline testing. So these both are done using next generation sequencing. So this is the technique which is used for this germline testing. And germline sequencing, it is a definitive test for Lynch syndrome, and it is always preceded by informed consent taken by a trained individual. Why? Because whenever you are going to do this germline sequencing, on the you have to do it for other family members also to find out other family members which who can be affected. So it can cause a significant psychological and physical impact also on those individuals, so that informed consent is required by a trained individual. But this is the most definitive testing for this Lynch syndrome. Now what is the new development for this Lynch syndrome is targeted therapies. You know, this main mechanism is MMR deficient cancers. Okay. So the pathway which is used for this MMR repair is PD1 or PD1 pathway. Okay. So this PD1, it is a druggable pathway, so that this drug can control this pathway. But they have found out, and which drug is useful is pembrolizumab. Okay, it is an Ig4 isotype antibody which targets PD-1 receptors which are expressed by peripheral lymphocytes. It binds and blocks the PD-1 receptors, preventing its activation. And this was licensed by US FDA. Okay, this is licensed by US FDA for the Lynch syndrome patient. So this is the targeted treatment which is used for this Lynch syndrome. So this is regarding the Lynch syndrome talk. We will come to one or two questions for this talk. Just type your answer in the chat box. Okay. So what is the definitive test for diagnosis of Lynch syndrome? Yes, it is a germline sequencing. Next one, all are true about Lynch syndrome except yes. So E answer is the correct because carriers of Lynch syndrome, they have 50% chance of passing the defective MMR gene to their children. Okay, so answer is wrong. All other things are about the Lynch syndrome, they are correct. Okay, so this is regarding the Lynch syndrome talk. I will inform you when I can do the next talk. I will just tell on that day and we can do those. Okay. So thank you for all of you for attending this session. I will post the recording on YouTube. Bye for now then.